Hey there, curious minds. Ever felt like you're drowning in information, trying to get your head around a really complex medical topic, especially one that affects so many people? Today, we're doing a deep dive into something super common, but wow, surprisingly tricky. Managing fluid overload in heart failure. Specifically, we're looking at times when the usual treatments, the diuretics, just aren't quite cutting it. We want to get into why these standard meds sometimes fail and the really clever ways experts are tackling what they call diuretic resistance.
Yeah, it's fascinating, isn't it? How the body's own attempts to, well, compensate for a struggling heart can actually end up working against our efforts to fix the fluid balance. We'll dig into the subtle ways fluid builds up and why just upping a single medication often isn't enough. We need more tailored strategies. And it really makes you ask, are we actually tackling the root of the problem when we're trying to get that extra fluid off?
Exactly. That's the core question. So we're going to unpack how the body holds on to water, why common meds can stop working so well, and some pretty surprising multi-pronged approaches that are really making a difference. Get ready for some aha moments. You'll feel, I think, incredibly well informed by the end.
The weight of water understanding fluid overload in heart failure.
Okay, first things first, let's set the
Yeah.
stage. What exactly is heart failure? And why does it make patients carry around so much extra fluid? Sometimes they literally feel like they're drowning in it, right?
Right. So heart failure basically means the heart isn't pumping blood as effectively as it should. This leads to a backlog, congestion. This extra fluid can show up as pulmonary edema, that's fluid in the lungs, makes it hard to breathe, or it can be systemic congestion causing swelling all over, like in the legs, the abdomen. Managing this volume, this fluid status is, well, it's absolutely central when dealing with acute decompensated heart failure or ADHF. What's kind of counterintuitive is that the body's system's meant to keep blood pressure up, like the renin-angiotensin system. They go into overdrive in heart failure, and that just drives more salt and water retention. It's a vicious cycle.
Okay, so when someone's really struggling to breathe, that pulmonary edema picture, what are the immediate steps? How do you help their lungs right then and there?
Well, the initial focus is often lung support. Non-invasive ventilation, specifically BiPAP, that's positive pressure through a mask, is used a lot. It helps by reducing the workload on the heart, we call preload and afterload, gives the heart a bit of a break. In really severe cases, maybe if the patient's confused, they might need intubation,
Oh,
full breathing support, but that has its own risks, like blood pressure dropping.
right.
And if there's a lot of fluid around the lungs, pleural effusions, draining, that can give temporary relief. But, and this is crucial, just draining the fluid doesn't fix the underlying heart failure. It just helps stabilize the breathing for a bit.
Makes sense. It's a temporary fix for the breathing. So looking beyond the lungs, how do doctors figure out just how sick the heart is, especially in those really critical, like cardiogenic shock situations?
Yeah, for severity, we use classifications. The SAE-ISHOP stages are a common one. It goes from stage A, someone's at risk but not actually in shock, vitals, okay, lungs clear, all the way to stage E, that's extremis. Impending circulatory collapse, really low blood pressure, even with maximal support. Stage C is what people often think of as classic cardiogenic shock. There's hypoperfusion, not enough blood flow getting to organs, and it needs more than just fluids to fix.
Yeah.
And stage D means things are getting worse over time despite the initial treatment. It helps us gauge urgency.
That really paints a clear picture of the spectrum. But stepping back again, why does someone end up with heart failure to begin with? What are the common culprits?
Oh, the causes are pretty diverse. Often it's a sudden drop in the heart's pumping ability, like a heart attack, an acute MI. That accounts for maybe 75% of cardiogenic shock cases.
Wow, three-quarters.
Yeah. Other things include viral myocarditis and formation of the heart muscle, or heart rhythm problems, too fast or too slow. Sometimes it's sudden volume overload or even severe dehydration, weirdly enough. Heart valve problems, too. And we can't forget certain drugs, NSAIDs, some chemotherapies. They can contribute or worsen things. It's interesting how these initial triggers then activate those fluid retention systems that become so hard to turn off later.
That's a perfect segue. So once that fluid builds up, why is it so darn stubborn to get rid of? This leads us right into the main challenge today, diuretic resistance.
The stubborn truth unpacking diuretic resistance.
Exactly. Diuretic resistance is a huge clinical headache. Loop diuretics drugs like furosemide,
Ah,
they work by blocking specific transporter in the kidney tubules. That should increase sodium excretion, and water follows sodium, so you pee more out.
right.
But the body has several ways to fight back these physiological mechanisms that counteract the diuretic effect.
Okay, so what are the main reasons these workhorse drugs, the loop diuretics, might just stop working as well as we'd hope?
Well, one big reason is the diuretic needs to reach a certain concentration, a threshold level, inside the kidney tubules to actually work. If kidney function is poor, which often happens in heart failure, something called cardiorenal syndrome, the kidney might not actively secrete enough diuretic into the tubules.
Ah, okay.
So the drug just doesn't get to its target site in high enough amounts. You might need higher doses just to hit that effective threshold.
Mm.
Then secondly, there are these two related things: post-diuretic sodium retention and the braking phenomenon.
Mm.
Basically, after a dose of a loop diuretic wears off and they don't last forever,
Hmm.
the kidney senses that sodium loss and goes into overdrive, reabsorbing sodium really aggressively in other parts of the tubule. This can pretty much cancel out the fluid loss you just achieved.
Whoa.
And even more, if someone's on loop diuretics long term, the cells in the distal part of the tubule, the distal tubule cells, can actually get bigger and multiply hypertrophy and hyperplasia. This makes them even better at grabbing back sodium.
The kidney adapts.
It totally adapts. And that's a major reason why adding a different type of diuretic, like a thiazide, is so key. Thiazides block sodium reabsorption in that distal tubule, directly countering this adaptation.
So the kidney's literally building a workaround. How long did it take for doctors to really grasp this braking thing? And what was care like before this multi-drug approach was common?
Oh, it was recognized as a problem for a while, led
Yeah.
to a lot of frustration,
Uh,
for doctors and patients. Seeing patients not respond well, really understanding that adaptation pushed the field towards, okay, we can't just rely on one mechanism. Beyond that kidney adaptation, other things interfere too, like reduced blood flow to the kidneys. Less blood flow means less diuretic gets delivered. Improving heart function can sometimes help that.
Makes sense.
And honestly, a really common one, non-adherence. Patients not taking the meds as prescribed. It's often overlooked.
Sure.
And you mentioned NSAIDs earlier, those common painkillers. Big problem. They can directly interfere with how diuretics work and make the body hold on to sodium.
Yeah, that's huge given how many people take NSAIDs. What about issues with the drug just getting into the system in the first place, like absorption problems?
Absolutely. Impaired oral absorption can definitely be an issue, especially if someone has a lot of ascites that's fluid in the belly or swelling in the gut wall itself. That edema can stop pills from being absorbed properly.
Right.
In those cases, switching to IV diuretics bypasses the gut. Or sometimes using an oral loop diuretic that's known to have better absorption, like torsemide or bumetanide, can make a difference.
Okay, this next one sounds really tricky. You mentioned occult diuretic resistance. What on earth is that, and why is it deceptive?
Yeah, occult resistance is sneaky. It masks the real problem
Yeah.
because the patient might actually be making lots of urine, liters even.
So it looks like the diuretics are working great.
Exactly. It looks good on the surface. You see good urine output numbers,
Yeah.
but the urine is often very dilute. It means they're losing more water than sodium. So the patient can actually become hypernatremic, high sodium in the blood because they're losing free water. But the edema, the swelling in the tissues, which is mostly salt and water together in the extracellular space, that doesn't really budge much.
Wow. So you're essentially dehydrating the patient's cells without actually shrinking the harmful swelling. That sounds incredibly counterintuitive and hard to spot.
It is, because water moves freely between cells and the space outside cells, right? So if you pull off a liter of pure water, only about a third of that actually comes from the extracellular space where the edema is.
Okay.
So the patient might feel thirsty, agitated, still look swollen, still be volume overloaded, even though the urine chart looks impressive. It really hammers home that just looking at fluid balance, intake output, isn't enough. You have to think about what is being removed. Is it salt and water or just water?
Okay, clearly just cranking up one drug isn't the answer. The kidney's too smart for that. So how do we outsmart the kidney?
Attacking the problem from all angles, the multinephron blockade.
That's the million-dollar question. And the answer lies in this strategy called sequential nephron blockade. The idea is to use combinations of diuretics that work on different parts of the kidney's plumbing system, the nephron.
Hitting it from multiple angles.
Exactly. That way you get a more complete block of sodium and water reabsorption, sort of overcoming those compensatory mechanisms we talked about.
Okay, let's break that down. Starting with the backbone, the loop diuretics like furosemide. How do we make sure we're using them as effectively as possible?
Right. For loops, step one is finding an effective dose. Often that's done by just trying doses. Give a dose, wait an hour or so, no response, double it. keep going until you get a good response. The goal is usually something like over 150 milliliters of urine per hour for the first couple of hours. That tells you you've hit an effective dose.
Okay, dose finding first.
Then the dosing interval is critical. Remember that breaking phenomenon. An IV dose of furosemide might only really work for about 2 hours.
Only 2 hours.
Mm.
Wow.
Yeah, so if you give it just once a day, that leaves 22 hours where the kidney can grab back sodium. So more frequent dosing, say every 6 or 8 hours, or even a continuous IV infusion, can help overcome that post-diuretic sodium retention. Keeps a more steady pressure on the kidney.
Are continuous infusions always better than giving bolus doses, like every few hours?
Not necessarily. The evidence isn't totally clear that one is always superior for everyone. Continuous infusions are nice because nurses can easily adjust the rate to keep a steady urine output. They probably work best for patients who respond okay to moderate bolus doses, maybe 100 milligrams of IV furosemide or less.
I see.
But for patients who are really resistant, sometimes those high peak drug levels you get with a big intermittent bolus dose might be needed to kind of punch through that resistance threshold.
Okay, makes sense. Now for the combinations. What's the classic partner drug you add to a loop diuretic to tackle that breaking phenomenon in the distal tubule?
That would definitely be a thiazide or a thiazide-like diuretic. They specifically block sodium reabsorption in the distal convoluted tubule, so they hit the exact spot where the kidney tries to compensate for the loop diuretic. The result is a much bigger net loss of both sodium and water. It's a truly synergistic effect.
Powerful combination.
Yeah.
Which specific thiazides get used most often? And do they have different strengths?
Yeah, there are a few common ones. Metolazone is a popular choice. It's known to be highly effective even when kidney function is really quite poor, like a GFR less than 20. Part of why is it might also have some effect earlier in the nephron in the proximal tubule.
Interesting.
Indapamide is another excellent one. It has a really long half-life, around 24 hours.
Oh, wow.
Yeah, so that helps sustain the diuretic effect and prevents sodium retention between loop diuretic doses. Plus, it seems to be kidney protective and doesn't usually mess with blood sugar levels like some other thiazides can. And if someone can't take pills, there's IV chlorothiazide. It works, but its effect is shorter.
So adding that thiazide really changes what you're removing, not just how much volume.
Absolutely. There was a really telling study, the Bihari trial in 2016, in ICU patients with fluid overload. Patients who only got furosemide, they mostly lost free water. They got dehydrated, basically, but their actual tissue swelling didn't improve much.
Just like that occult resistance idea.
Exactly. But the patients who got furosemide plus indapamide, they lost fluid that was much closer to isotonic salt and water together. And that led to effective volume reduction, less edema. It really drove home the point. You need natriuresis, getting rid of sodium, not just diuresis, making urine.
That's such a critical distinction. Okay, what about newer players? We hear so much about SGLT2 inhibitors now for heart failure. How do they fit into this diuretic strategy?
The SGLT2 inhibitors. Drugs like empagliflozin, dapagliflozin, they've been a huge leap forward in heart failure care, really. Doesn't matter if the ejection fraction is low or preserved, or if the patient has diabetes or not.
Right, they seem to work broadly.
They do, and they work way up in the proximal tubule, even earlier than loops. They make you excrete both sodium and glucose. They seem to make loop diuretics work better, they protect the kidneys long term, and they significantly cut down heart failure hospitalizations. Big studies like Emperor-Preserved and MPAG-HF support using them early, even starting them while patients are still in the hospital. They're definitely part of the modern toolkit.
Sounds like a game changer.
Yeah.
Now, what about a much older drug that seems to be making a comeback here, acetazolamide?
You're right. Acetazolamide is back in the conversation. It's a carbonic anhydrase inhibitor. Also works in the proximal tubule, like the SGLT2s. It's particularly handy because it helps treat metabolic alkalosis that acid-base imbalance loop diuretics can cause. And it can help with potassium levels, too. There was a big trial, the ADVOR trial. It showed that adding 5E acetazolamide to furosemide significantly improved decongestion, got more fluid and sodium off in hospitalized heart failure patients. It might not be as helpful, though, if someone's already on super high doses of furosemide, or if they're also taking an SGLT2 inhibitor, might be too much overlap in mechanism there.
So again, it's about tailoring the combination.
Yeah.
Got it. What about amiloride?
Amiloride is a potassium-sparing diuretic. It blocks a specific channel, the NSE channel, later in the nephron in the distal part. Its advantage is that it starts working pretty quickly, much faster than spironolactone, another potassium-sparing drug.
Uh-huh.
So it's useful for acute management. It helps create what you might call a balanced diuretic strategy. It counteracts the potassium loss, the alkalosis, sometimes the highest sodium levels you can get with loops and thiazides. So it helps get rid of sodium while holding on to potassium. Very useful for managing those electrolyte side effects.
And how does spironolactone fit in then? You mentioned it's slower.
Yes, spironolactone is incredibly important for chronic heart failure management. It has proven long-term benefits, reduces mortality, no question about its value there, but its diuretic effect is sluggish. It takes a day or two to really kick in fully.
Too slow for an emergency.
Exactly. In an acute situation where you need to get fluid off now, it's just not the right tool for rapid diuresis. It's more for long-term maintenance or specific situations like severe cirrhosis where aldosterone levels are sky high. It really shows you need the right tool for this specific job at hand, doesn't it?
The paradoxical approach, hyperdiuresis.
Okay, this next part sounds really wild, maybe even counterintuitive. What happens if even these multi-drug combinations aren't cutting it? I've heard people talk about hyperdiuresis. It sounds like giving more salt to get rid of salt. How on earth does that work?
Yeah, this is definitely pushing the envelope. It's a strategy for really refractory cases. The core idea hinges on something we often ignore. Chloride. Serum chloride level.
Chloride?
Yeah. Studies show that low chloride levels, hypochloremia, are strongly linked to worse outcomes, higher mortality, and heart failure, independently linked. But even more relevant here, low chloride might actually promote sodium retention. It seems to stimulate renin release and rev up sodium channels in that distal tubule.
So the low chloride itself is telling the kidney to hold on to salt.
That's the thinking. So hyperdiuresis involves giving hypertonic saline concentrated salt water, like 150 milliliters of 3% saline, at the same time as a big dose of an IV loop diuretic, like furosemide.
Giving salt and a diuretic together.
Okay, the hypertonic saline is thought to do a couple of things. One, boost the chloride levels, hopefully reversing that hypochloremia-driven sodium retention. Two, it acts osmotically. It pulls fluid from the sworn tissues into the bloodstream.
Refilling the tank, so to speak.
It's exactly. Making the fluid more accessible for the kidneys to remove, potentially without tanking the blood pressure or intravascular volume. And there's another synergy. Loop diuretics block something called tubuloglomerular feedback, which high chloride can sometimes trigger. So the loop helps keep the diuretic effect going, even with the extra chloride load.
That's fascinatingly complex. What's the evidence like for this? It sounds risky.
It's still somewhat controversial and maybe not for everyone. Some early studies had issues, but several other studies, including a randomized trial from Brazil, suggest it could be safe and effective when other methods have failed. That Brazilian study showed giving hypertonic saline with furosemide led to less kidney injury, less rise in creatinine, and maybe more weight loss compared to just furosemide alone in decompensated patients. Other studies hint at faster diuresis, shorter hospital stays, fewer readmissions. It's generally seen as an option for patients who are really stuck, heading towards dialysis maybe when you've tried the sequential blockade and it's not enough. It really underscores how intricate fluid and electrolyte balance is.
Navigating the minefield, managing diuresis complications.
Okay, so we're using these powerful strategies, pulling off lots of fluid. Things can go wrong, right?
Right.
What are the common bumps in the road, the complications we need to watch out for? And how do you handle them without stopping the whole decongestion process?
Absolutely. Aggressive diuresis isn't without risks. Electrolyte problems are really common. We already touched on hypernatremia, high sodium, hypokalemia, low potassium is very common, and metabolic alkalosis, that acid-base shift.
Right.
The key thing to realize is that these are often iatrogenic complications, meaning they are predictable side effects of the diuretic strategy itself. They don't automatically mean the patient is now dry or that they can't tolerate more fluid removal. They mean we need to manage the side effects.
So let's say the sodium level starts creeping up hypernatremia. The instinct might be stop the diuretics. Is that always right?
Not necessarily, no. If the patient is clearly still fluid, overloaded, still swollen, congestant, you don't stop trying to get fluid off. Instead, you manage the high sodium by giving free water. That could be IV D5W, which is dextrose in water, or just encouraging them to drink water if they can. You treat the side effect while continuing the main therapy.
Okay, treat the number while still treating the patient's volume status.
Exactly. Same for low potassium. You have to replete it aggressively, Often, IV potassium is needed. For metabolic alkalosis, you might need to add a diuretic that wastes bicarbonate, like acetazolamide or maybe amiloride, to correct the pH. If you don't actively manage these electrolyte shifts early, they will get worse, and that might force you to stop diuresis prematurely.
Makes sense. Proactive management. Now, what about the kidneys? We often see the creatinine level, that marker of kidney function, go up during aggressive diuresis. How worried should we be?
Yeah, a rising creatinine always needs attention. You have to make sure there isn't some other cause of acute kidney injury happening. But if the patient is clearly still congested, still overloaded intravascularly, sometimes continuing the diuresis is actually the right thing for the kidneys. Relieving that systemic congestion can improve blood flow to the kidneys in the long run. There's a condition called congestive nephropathy, where kidney function improves as you decongest the patient. So, small bumps in creatinine in a clearly wet patient might be acceptable, even expected, and might actually improve with continued fluid removal. It's important to remember diuretics themselves aren't usually directly toxic to the kidney unless they cause severe volume depletion, leading to poor blood flow.
That's a really important nuance. So wrapping this all up, what's the big takeaway for our listener who wants to really understand this critical area of medicine? Outro.
I think the main takeaway is that managing fluid overload and heart failure is, well, it's much more complex than just prescribing a diuretic and hoping for the best. It's about understanding how incredibly adaptive the kidney is, how it fights back. It's about recognizing those subtle forms of resistance, like the occult type, where urine output looks good but isn't actually helping. And it's about strategically using multiple tools, hitting different parts of the nephron to achieve effective decongestion. It's a very dynamic process, constantly assessing, adjusting, and monitoring how the body is responding.
Yeah, we've really journeyed through the complexities today, haven't we? From that braking phenomenon where the kidney puts the brakes on to the power of hitting it from multiple angles with sequential nephron blockade, and even that mind-bending paradoxical idea of hyperdiuresis. You should now have a much clearer picture of why just one diuretic often falls short and how these combinations, adding a thiazide or an SGLT2 inhibitor or acetazolamide, can make such a crucial difference. Moving from just losing water to truly decongesting the body by removing salt and water.
And maybe this leaves you with a critical question to ponder. When you encounter or hear about someone with fluid overload being treated, are the strategies focused on removing the harmful tissue edema, the actual swelling? Or could they be inadvertently causing unproductive dehydration by just pulling off free water? Thinking about that distinction, natriuresis versus just diuresis is key for effective care.
That's a perfect thought to leave everyone with, a really critical distinction. We really hope this deep dive has armed you with a much deeper, actionable understanding of this complex but vital topic. As always, stay curious and keep exploring.